Thank you, Dr. Walker, for inviting me to participate in this very important digital educational series by NCVH. Reducing cardiac complications in PAD patients by improving non-invasive cardiac diagnostics and selective coronary revascularizations is the topic of my presentation. Here's my disclosure. Cardiac complications are the primary cause of death of patients with peripheral arterial disease. Patients undergoing revascularization surgery have a high postoperative death and myocardial infarction rates. 3% 30-day mortality is recorded in the NISQIP database. 20% 2-year mortality and 50% mortality rates are the norm. Patients with postoperative myocardial infarction have significantly increased risk, as do patients with postoperative troponin leaks, which may be asymptomatic. Patients may have significant myocardial injury and not know it clinically after surgery. Yet it profoundly influences long-term survival. For patients with peripheral arterial disease undergoing revascularization, 5-year mortality rate or survival rate is 73%. The survival rate of patients with postoperative myocardial injury is 50%. And for those who have frank myocardial infarction is only 33%. Despite this very high mortality rate, which is well recognized, coronary artery disease is often unrecognized in patients who are undergoing peripheral arterial disease revascularization. Patients are elderly, they're sedentary, they have impaired ability to walk, and they often have no chest pain or symptoms of coronary disease. They may have silent myocardial ischemia and not know it. And patients who do have silent myocardial ischemia have a high risk of adverse events. Now, silent ischemia can be determined non-invasively with ambulatory ECG monitoring, myocardial perfusion tests, stress echocardiography, SPECT, PET, and MRI. But many of these non-invasive tests have a low sensitivity, and they often miss disease. Patients with silent ischemia, as you can see in the chart on the right, have a reduced survival. And it doesn't matter whether you have symptoms of ischemia or don't have symptoms of ischemia. The mere presence of ischemia itself is a predictor of adverse events and reduced long-term survival. Well, we know that most patients with PAD do have significant coronary disease. We've known this for more than 30 years. If you do routine coronary angiography and you define significant stenosis as 70% or more, you find that more than 50% of patients have significant coronary disease. It's highest actually if you have carotid disease, 64%. Lower extremity disease, 52%, aneurysm, 50%, all locations, 55% in this large systematic literature review. But one important thing to note is that this is anatomic stenosis. It does not tell you functionally significant. So we don't know if these are ischemia patients or non-ischemia patients. They have anatomic disease. And anatomic disease by coronary angiography cannot determine the functional significance or ischemic potential of coronary disease. So what did we do? What kind of preoperative evaluation do we do? Well, the guidelines recommend a stepwise approach. And if you look at the picture, that stepwise is pretty contorted and difficult to follow. But what it basically says is that you estimate preoperative risk. You determine whether you think the risk is low, less than 1%, well, then you just proceed with surgery. Or you think that the risk is high, greater than 1%, and then you assess the functional capacity. Can the patient walk? Can the patient exercise? Do they have shortness of breath? And so on. And as you know, most patients with peripheral arterial disease have problems walking. They do have functional impairment. But guidelines say that even if the patients have some degree, you're just estimating the combined clinical surgical risk. And then they say stress testing maybe, but only if it would change perioperative management. Routine screening of non-invasive tests is not useful. Why? Because what happens if you do the test and you find something? Well, then you go on to coronary angiography, and we know that coronary angiography provides no benefit, so why do it? So the bottom line is they say treat with best medical therapy for atherosclerosis. And what's the result of that? Well, it turns out that these patients now have a high mortality rate. In this recent study, which was just published in JAMA Surgery this year, a statewide registry of 26,000 patients who undergo vascular surgery showed that 72% of the patients had no preoperative cardiac stress testing. Well, this is in accord with guidelines. You do a risk-benefit assessment and then go ahead with your surgery. Now, the actual results were not that bad. Post-operative myocardial infarction occurred in only 1.6% of patients. This is lower than historically we have been seeing. But what is astounding is that the one-year mortality of those patients who had post-operative MI was 7% against 5% of patients who did not have post-operative MI. This was highly significant. So a marker for severe risk is patients who have post-operative mortality, post-operative myocardial infarction. Now, this high mortality occurred despite evidence-based medical therapy in almost all patients. The authors concluded that the mortality after myocardial infarction in the general population is 3.8%, but the mortality following post-operative myocardial infarction after vascular surgery has remained staggeringly high, more than 20%, and is nearly constant since 2009. So the past 10 years, past decade, there's been no improvement in the problem of post-operative deaths and myocardial infarctions in vascular surgery patients. So what happened in 2009? Well, in 2009, there were significant advances in cardiology, and that was the publication of the FAME study results in the New England Journal of Medicine. This compared FFR-guided coronary revascularization to angiography, visual angiography-guided coronary revascularization. Now, fractional flow reserve, as you know, is measured in the cath lab using a guide wire across the coronary lesion. And under conditions of maximum hyperemia, the pressure gradient is determined. And this tells you whether or not that stenosis is hemodynamically significant. This is like an ankle brachial index, a physiologic measurement of significant disease under maximum stress conditions of hyperemia. If you have an FFR value of less than 0.8, that is hemodynamically significant, and those patients may benefit from coronary revascularization. If you have an FFR value of greater than 0.8, then coronary stenting or coronary revascularization really provides no benefit over medical therapy, and that is the best strategy for those patients. So the evidence for reduced mortality with FFR-guided coronary revascularization is very, very strong. It comes from prospective randomized trials. In a meta-analysis of more than 2,400 patients, there was reduced death and MI with FFR-guided revascularization in controlled prospective randomized trials. Within those trials, the patients who benefited most were those with silent asymptomatic coronary ischemia. So the 5-year death rate in the FAME-2 trial for patients with asymptomatic ischemia was 31% compared to 14% in those with symptomatic ischemia. In a real-world experiences now coming out, there's very strong evidence of improved survival with FFR-guided revascularization, both at 1 year and at 5 year, with significant reductions in mortality with FFR-guided coronary revascularization. Well, it is now possible to get that same measure, fractional flow reserve, non-invasively using coronary CT scans as a basis. Computed FFR has been validated against invasive FFR in patients with symptomatic coronary disease. And on the 3D map of FFR values, you can see with a color-coded map where the significant lesion is, and the vessels in red are hemodynamically significant, and those in green and blue are not. Non-invasive FFR assessment is now FDA cleared. It is Medicare and private insurance reimbursed, and it is in common use for patients with coronary artery disease. Well, how does this work? Well, you do a coronary CT scan, which shows a 70% LAD stenosis in 2 patients. They both have calcium, and they both have stenosis visible on the coronary angiogram. If we do computational analysis of that CT scan, we can now see that patient A does not have a hemodynamically significant lesion with an FFR value of 0.86, whereas patient B does have significant ischemia with an FFR value of 0.7. This is now validated against coronary angiography and measured FFR. And we see that patient A has an FFR value invasively measured of 0.87, correlates very well with the computed value. And in patient B, again, the measured FFR value of 0.71 correlates with the computed value of 0.70. Thus, the information that is now driving cardiology, measured FFR, seen on the right, can be obtained non-invasively prior to coronary revascularization on an outpatient basis based on the coronary CT scan with computational analysis. So, does this have value in patients with peripheral arterial disease? A study has been performed in Riga, Latvia, which was the major site for clinical validation of invasive FFR versus computed FFR. And this now is led by the head of vascular surgery in Riga, Latvia, Professor Zarins. He's conducting a study of preoperative coronary CTA and FFRCT. This is an open label study so that the results are available to the physician for patient management decision. And ischemia is defined as FFRCT less than 0.8 distal to a stenosis, and severe ischemia is defined as FFRCT less than 0.75 distal to a stenosis. Now, notice this is greater than 30% stenosis. And the reason for that is that there are patients in the 30 to 50% stenosis range who have significant disease. There are also patients in the 50 to 70% range and 70 to 90% that do not have hemodynamic significance. So the broad range of stenoses are evaluated for functional significance. The first publication from this came out in Vascular Disease Management in 2018. It reported on 54 patients with critical ischemia. None of the patients had coronary symptoms, and they were admitted on clinical grounds for lower extremity revascularization. Routine preoperative testing revealed that 69% had silent coronary ischemia. Now, despite this level of ischemia, the patients underwent vascular surgery as guidelines recommend in 91% of the cases. What was different in these patients compared to previous experiences, that these patients now underwent post-operative coronary revascularization on the basis of their preoperative evaluation demonstrating silent coronary ischemia. Here's a case example. This is a 59-year-old man with superficial femoral artery occlusion and ischemic rest pain, ankle brachial index of 0.45, and he came in for scheduled saphenous vein femoral popliteal bypass. The bypass was performed successfully, and 1 month after his surgery, the right coronary stenosis was treated. The patient was taken to the cath lab. The angiogram confirmed the presence of a 90% right coronary stenosis, as demonstrated with the red arrow, and the patient was treated with a coronary stent with complete relief of the stenosis. So the question comes up, can the diagnosis of silent coronary ischemia using CTA and FFRCT reduce cardiac complications following peripheral vascular surgery? This was a prospective, open-label, IRB-approved study for patients with no cardiac history or cardiac symptoms who were admitted for lower extremity revascularization. All patients had standard preoperative evaluation, and in addition, had coronary CT and FFR-CT. They were matched against historical controls, again with no cardiac history or coronary symptoms, who had elective lower extremity revascularization during the immediately preceding prior year. These patients also had standard preoperative evaluation consisting of history, physical, and exam, and because they had no cardiac symptoms or history, had no cardiac stress testing. The endpoints at 1 year were cardiovascular death, myocardial infarction, all-cause death, and major adverse cardiac events defined as cardiovascular death, myocardial infarction, or unplanned coronary revascularization. Here we see the study groups. There was no difference between the two groups with an age of about 65, 66 years. About 80% were men and 20% were women. There were no difference in preoperative comorbidities and medications, and the primary operative indication was critical limb ischemia, and more than 80% in both groups. Most of the procedures performed were femoral popliteal outflow procedures, with about 40% being inflow procedures in the aortoiliac segment. Here we see the results of FFR-CT analysis demonstrating lesion-specific ischemia in 2 out of 3 patients. 68% had FFR-CT less than 0.8. 40% were single vessel disease, and 60% had multi-vessel disease. And importantly, the severity of disease was very high, with FFR less than 0.75 in more than half the patients, 53%. It's important also to note that left main stenosis was present in 7% of the patients. These are highly significant lesions and could benefit from coronary revascularization. So how were these patients managed? Vascular surgery was performed as planned in 96% of patients in the prospective study. There were no postoperative deaths and only 1 myocardial infarction. Vascular surgery was postponed in 5 patients, 1 for coronary revascularization and 4 for medical therapy. In the control group, all patients had lower extremity revascularization, and 5 patients had postoperative cardiac deaths, and 7 had myocardial infarctions. Both groups received optimal postoperative medical care. Here is a patient example, 67-year-old diabetic man with ischemic rest pain in the left foot. He had no cardiac history or symptoms and was admitted for a femoral popliteal bypass. Preoperative coronary CT scan revealed 70% right coronary stenosis and less than 50% left anterior descending coronary stenosis. As you can see, this patient is severely calcified with a calcium score of 3,873. The FFR-CT analysis showed a focal lesion in the left anterior descending coronary artery with distal ischemia with an FFR value of 0.52. There is no significant ischemia in the right coronary artery. As you can see, it is all blue on the FFR-CT analysis. The patient had his surgery and relieved his lower extremity ischemia, and then 1 month postoperatively underwent coronary revascularization, which confirmed 90% stenosis in the left anterior descending artery, seen in the red arrow, and this was treated with a coronary stent. The patient did well and was doing well with no symptoms at 1 year. Selective postoperative coronary revascularization was performed in 75 of 86 patients with coronary ischemia, that is 87% of all patients. This was performed 1 to 3 months after recovery from vascular surgery, and patients were particularly studied if they had left main disease, severe ischemia, or multivessel ischemia. 54 patients had coronary revascularization, 47 with coronary stenting, and 7 with coronary bypass. This represents 72% of all patients with silent coronary ischemia. Here we see a patient with left main disease and severe multivessel ischemia with a calcium score of 2,323. This patient had femoral end arterectomy to relieve ischemia, and 6 weeks later underwent lower extremity revascularization with 6 weeks later underwent coronary bypass. This patient had left main disease and severe multivessel ischemia. He underwent femoral end arterectomy. As you can see, he had coronary artery bypass 6 weeks after successful lower extremity revascularization. Here we see the results. A 30-day outcome revealed no significant difference between the two groups, although there was a trend to reduced cardiovascular death, myocardial infarction, and all-cause death in the FFR-CT group. This did not reach statistical significance. At 1 year, there was a significant reduction in cardiovascular death in the CTA-FFRCT group compared to control. There was also a significant reduction in myocardial infarction, 2.2% versus 8.1% in control. There was also a significant reduction in all-cause death, 0.7% in CTA-FFRCT and 5.9% in the control group. There was no significant difference in MACE between the groups. It should be noted that the only death in the CTA-FFRCT group was due to a stroke. It was not due to a cardiac death, but it does count as a cardiovascular death, of course. 1 year Kaplan-Meier results show a reduction in cardiovascular death, reduction in myocardial infarction, and improved 1 year survival in the CTA-FFR group. 1 year survival was 99.3% in CTA-FFR and 94.1% in the control group. So in summary, patients preoperative evaluation of peripheral arterial disease patients with CTA-FFR reveals a high prevalence, 68% of unsuspected silent coronary ischemia. Diagnosis of silent coronary ischemia can reduce cardiac complications by risk stratifying patients and facilitating multidisciplinary vascular care to optimize medical care and select patients for coronary revascularization. Compared to standard care, in the CTA-FFR group, at 1 year, cardiovascular death was reduced, myocardial infarction was reduced, and survival was improved, 99% versus 94%. So in conclusion, improved non-invasive cardiac diagnostics, that is coronary CT and computational analysis of FFR, and selective coronary revascularization can reduce cardiac complications in PAD patients. Prospective long-term controlled studies are needed to further define the role of CTA-FFR in PAD patients. Thank you for your attention.